Good morning, everyone, and thank you so much for taking part in this webinar about drug use and homelessness. Just for everyone to know, this webinar will be recorded, so if you don't wish to appear in it, please make sure to turn off your camera. This webinar is a part of a series of webinars that we are organizing inside the project Epoch Practice, and this is the 9th of them. So if you are you missed some of them, you can always check them on our website, and there are new coming. And the next one is going to be about our brief of good practices to tackle homelessness. So I hope you will not miss it. But about today, we are going to discuss about, as you know, drug use and homelessness together with Joanna Moura, research officer from the Correlation European Harm Reduction Network. We will have her presentation, a bit of context on what is happening at EU level from my side, and then we will have a half an hour Q&A. So if during the presentation you want to drop off your question in the chat box, feel free to do it. And also, if you prefer to turn on your camera and ask directly the question to Joanna at the end of the Q&A, it's also possible. So I hope you will enjoy the webinar. And Joanna, the word is yours.
Hello, everyone. Good morning. My name is Joanna. I work for Correlation. I'm gonna share my presentation now with you. I would like to invite you. I would love to know what everyone is doing, but that would take way too much time now at the webinar. So if you would like to drop your background and what you do in the field, or if you don't work in the field, why are you interested in this topic, please do so in the chat. Sylvia, is my presentation well shared? Okay, so as I said before, my name is Joanna. I work for Correlation. We are a network of harm reduction organizations all across Europe. We work a lot with providing the space for organizations to have mutual support. We do a lot of research as well, so that our advocacy is data-driven. And we work a lot to promote civil society's meaningful role in local, national, and European policy making, especially in the drug use field, but also in the intersection with social and health fields. So our stand is very much driven by human rights and by social justice. What's I think interesting to know about me is that before becoming a full-time researcher, I was also working in the field. I worked more than 3-4 years at a drop-in center in Amsterdam. And before that, I also worked in outreach harm reduction in Portugal. I worked at a drug consumption room, and most of my time I worked with European migrants who are using drugs and who are experiencing homelessness. Only recently, so about 1 year ago, I moved to research. So this presentation will be based on my experience as a practitioner and as a researcher and as an evidence-based practitioner. So to start with this webinar, I would like us to take a little moment to reflect upon our own biases and our own assumptions, our own thoughts about people that we work with in this field. So I'm going to share a Mentimeter code so that we can reflect on the words that we connect with people experiencing homelessness and then people who use drugs. I would like to invite you to write whatever comes to your mind. This is not supposed to be a judgmental place, but rather more a place where we think about our own thoughts. And it's anonymous, so I will not know who wrote what. And I'm going to give you about 5 minutes for each part. Okay, so now I'll stop sharing this part. so sorry. I know that when we do webinars, this little moment of technicalities is always a bit weird. Okay, so here we go. I know that Sylvia and Arnold will also share the code over the chat. So the idea is that you can either scan the QR code with your phone or go to menti.com and enter this code, and then we will have these questions. The answers will pop up here. I would like to invite you to start writing on this one, on this question, what comes to your mind when you think of people who are experiencing homelessness, and please let me know if there's something that is not working. Okay, I think we have quite an extensive cloud when it comes to people experiencing homelessness. So now let's move forward to people who use drugs. Thank you so much for your participation. Now let's have a look at it together. Starting with the cloud on people experiencing homelessness, I like to see, and unsurprisingly, from a start, that the amount of words and the diversity of words in this cloud really shows that most likely many of the people in this audience are already um, very much in contact with the target group and working with the target group. For example, I did this little cloud with psychology of a university once, first year students, and it was surprising to me to see that many words they associated with people experiencing homelessness would be sad, loud, poor, dirty, troubled past, unlucky, poverty, addiction, and drugs, for example. And in another situation, for example, in my daily life as well, when I used to say that I work with people experiencing homelessness, people would say, ah, yes, they are experiencing homelessness because they use drugs, right? So this kind of unspoken notion that if people are experiencing homelessness, it's almost big for their own fault always. When we know that homelessness can happen for a wide variety of reasons, it feels like nowadays with the housing crisis, people are more open to saying that indeed people can become homeless because they are poor or because they are they were married and now they get a divorce and they don't have money to rent a house by themselves anymore, because they have family conflicts, because relatives die, because they don't have a job. And sometimes it feels like in the media that this comes up as if it was a new thing, whereas this was always the case. People become homeless for so many reasons. And another thing that also strikes me is this idea that people who use drugs then are homeless because they use drugs. And once I also talked with the other students at another university, and they were super surprised when I told them, well, sometimes people might start using drugs when they are on the streets because they need to cope with the hardships and the situation on the streets. So there is like this stigma that is connected with a person that experiences homelessness, and that then can be exacerbated when they use drugs. I also like to see that a lot of vulnerability, exclusion, discrimination, poverty. So this idea that takes the blame out of the person that experiences homelessness. Now, when we move to people who use drugs, I also see a lot of what I just said, an escape, a coping mechanism that sometimes is indeed related with the experiences of homelessness, and that can also be related with other early experiences. But I also like to see this idea of pleasure and this idea of partying, because drugs can indeed have so many meanings. There's so many reasons why people use drugs. But when people use drugs and are experiencing homelessness, it feels like then they are to blame for their own situation. That is, so people are they're already not well seen, and people are experiencing homelessness, which is taken as probably their blame, and even more so when they use drugs. So I really just wanted to start this webinar to reflect with you about this idea of the double stigma of the intersection that is not always so direct and so one-sided, and demystify these assumptions. So now I'm gonna stop sharing this since the webinar is gonna be recorded, you will always have access to these clouds. Maybe you also want to use them for your own reflection. That's completely fine. And for your future work, that's also really, really fine by me. Okay, and now I'm really sorry for this, all these technical moments. Okay, you cannot see yet, but you will see in a bit. Okay, so as I was saying before, the intersection between homelessness and drug use is very complex, is bidirectional. So we know that experiencing homelessness can influence drug use, and drug use can influence the experience of homelessness. We also know that this intersection is way more when people are experiencing homelessness long term, or they have recurrent episodic homelessness situations. Yeah, and what I already said before, what also sometimes is difficult is that when a person experiences homelessness and uses drugs, it feels like the use of drugs takes the main stage. So not the fact that the person is unhoused, not the fact that the person is on the streets and therefore is struggling with everything else that the person that experiences homelessness is. So the basic needs, the constant search for a shelter, for a job, for means of survival, but the fact that uses drugs. And that means that if the drug use is considered then the main problem, so are the solutions. So the solutions are focused in abstinence, in stopping drug use, rather than addressing the lack of housing, which is a very factor that provides stability and predictability for all of us in life. So by focusing on drug use, we overlook that people use drugs to cope with homelessness, as we all said before, that drug use can simply happen alongside homelessness and has nothing to do with the fact that the person is homeless. And also that if people are using drugs as a means of coping, either with their situation or past experiences, then we are taking the only thing that keeps this person going without giving any alternatives or any way of the person dealing with those same things, and without having a house. So these are the dangers, in my opinion, on focusing on abstinence and also with having an evidence-informed stand. This is not to say, of course, that abstinence cannot be a strategy. For some people it is. It's just that there's strategies beyond abstinence that can also be accepted, and that abstinence requiring abstinence is many times just a moral stand and not something that will in fact help this person. So when we talk about harm reduction, I'm assuming that many people know what is harm reduction. Please, if that's not the case, do tell me. But I think when we talk about harm reduction, many people connect it with a set of interventions, which is as well like drug consumption rooms, providing means to test for communicable diseases, providing naloxone, drug checking services, or perhaps the most known, the opioid agonist therapies. But harm reduction is more than a set of these interventions. It goes beyond the needles. It's not only about providing the hygienic and safe spaces for drug use, but it's also about addressing social determinants of health, housing, food, education, and employment. And we do this, and that's our stand at correlation, because as harm reductionists, we want to respond to the causes of harmful drug use and alcohol use without eliminating such use itself, because we know that that's not an option for many people. And we want to focus also in structural factors that exacerbate the vulnerability, such as criminalization, stigma, but also housing status. So a little bit of data. I'm a researcher, so I promise this will be just a little bit of the presentation, very short, but just to give a bit of contextualization. That's why I bring data. At Correlation, every year we monitor harm reduction organizations. As I said, we are a network, so we have a set of members that are harm reduction organizations. And among these members, there's a few organizations that choose to be our focal points. Focal points are for us organizations that contribute to our data collection. And in this case, the monitoring serves for us to know what is the state of harm reduction services in Europe. So these are the participating focal points in 2024. The data for 2025 will come at the end of the year. If you want, you can scan the QR code here, and that will lead you to the report of last year. Today here, I'm not going to focus in everything. I'm really just going to focus in the intersection between harm reduction services and people experiencing homelessness. So naturally, since the intersection is so preeminent, what we know is that most of our harm reduction services that belong to us and that collect data for us also provide services for people who are experiencing homelessness. However, when we ask them to what extent are shelter and housing services available for people who use drugs, many say that they are only available to a small extent or to some extent. So that means that they are not widely available. When we try to zoom in into this data and understand where the availability is lacking and where the availability is better, we see that, for example, Central European and Southern European cities like Amsterdam, Antwerp, Barcelona, Bielefeld, and Zurich are among the cities where the shelters and housing are more provided to people who use drugs. And cities like Nicosia, Podgorica, Skopje, Sofia, Stockholm, and Tbilisi are among the cities where shelters and housing are less provided. So more to the east, east of Europe. Then when we ask, because maybe shelters and housing are not so available, but maybe our organizations are able to cooperate with housing and shelters services, what we learn is that the cooperation with housing and shelter services is challenging. And now there's multiple reasons why this can be. We do not have data on why this cooperation is challenging and when is cooperation good, but we could imagine, for example, if a harm reduction organization has a set of visitors and wants to put them on lists for shelters and is not able to because they use drugs, then that would be a bad cooperation. And from other research, when we try to understand indeed which barriers can prevent people who use drugs from accessing shelter and housing, we see that abstinence is often a condition and therefore a barrier for people who use drugs who are not ready or do not want ever to quit drug use to access them. So these end up excluding many people from shelter, and it does not result in any good results for anyone. Another thing, though, that I know it's often difficult to get around in services because indeed services have opening hours related to many because of many factors, and it can be from agreements with the neighborhood, and sometimes we cannot get around that. But what we know is that having really early opening hours can also be um, a barrier for many people who use drugs, or any social support services that follow traditional working hours. For example, sometimes early check-ins do conflict with realities of people who use drugs that need to make money late until the night, because that's when people are outside. And then people cannot go to the shelter and are forced to find an alternative. Another thing that I also think this might be an aspect that is not restrict to people who use drugs, but and I know that this is a difficult thing to get around when we work in shelters, and I think this is why we should also try to move from shelters to housing facilities, to permanent housing, is the need to move belongings daily. So very often shelters that are not 24-hour shelters or temporary shelters change lists of people sleeping there every day. And for many people, having to transport personal belongings every day is exhausting, especially for some people that need calm and stability. I'm thinking, for example, of people that also have psychiatric conditions. And this constant movement and instability often push people to just find a place on the street where they know they will be able to stay for longer and keep their belongings. And then, of course, the non-recognition of specific needs. When I say that we need to consider that people might be using drugs, and that is not a factor, that is not always a factor for them to be homeless, and that we have to have supportive services for people who use drugs. I'm not ignoring that they have specific needs. They might, and that's we have to take into consideration that when we want to make supportive services. So, for example, if we fail to recognize that maybe mornings will be difficult when people are did not use drugs the whole night, then we might face ourselves with difficult mornings with visitors, and so then we have to learn how to deal with that. We also need to learn about drug use and know if some people might be doing well on methadone the whole night, other people might require different approaches. And this idea of also knowing that different patterns of use require different types of support, as well as different people require different types of support. So if we want to really do inclusive shelter solutions, we should accept that some people will use drugs, and instead of forcing abstinence, just try to adequate our services. Maybe we can consider allowing drug use in shelters. And I know that some people, when we say this, are afraid. I know that some people are afraid that people will overdose in front of them, and then they are very scared that they will not know what to do. And I know that many people mean well with that. But the solution shouldn't be excluding people who use drugs from shelters because we are afraid. It should be learning on how to deal with these situations so that we can include people and provide them a chance for stability. Maybe we can consider providing paraphernalia to reduce harm. Of course, drug use and certain routes of administration of drug use come with known risks, like the spread of hepatitis C and HIV and other communicable diseases, and providing paraphernalia keeps people safe. We can also develop overdose response protocols, train staff, and ensure that maybe more than one worker is present, so that the one person does not feel so vulnerable to possible issues. And if it's not possible to allow people to use inside if it's possible to allow people to use inside, then it's also good that we think of ways of disposing the paraphernalia well and safely. Now, there's also quite some systemic barriers to care for people who use drugs. Lack of housing. I know this is a common struggle, not only for people who use drugs, but the average person nowadays. But people who use drugs often and who are experiencing homelessness often lack permanent or at least long-term housing due to stigma and lack of options. Uh, Although we know that permanent accommodation strongly supports safer drug use and is also a condition from recovery from drug use. So that's also something we should consider when including people who use drugs in housing solutions, is that it is also a way of promoting recovery. Sorry. I also want to talk about funding as a systemic barrier. I think it's well known that harm reduction services now are facing downgrading funding. So governments are less willing to fund harm reduction services, which is extremely concerning because harm reductions are often the only services that cater services to people who use drugs, be it because they do provide services that address their drug use, but also because they are low threshold and non-judgmental and accepting. And so it's very concerning that funding is being cut. I also would like to take a look at legal regulations as a systemic barrier. We know that in many countries around Europe and around the world, drug use is still criminalized. Or at least the possession of a certain amounts of drugs is criminalized, which can mean that people are present in prisons, for example, or are incarcerated way more often than they should, and then other people with no good results for anyone again. And once they are criminalized, then they will also face the stigma of having been incarcerated. This is something that we could explore in later in the discussion if you would like. Yes, but also, for example, we know that often this criminalization prevents people from accessing services as well. So that constitutes then a systematic barrier to care for people who use drugs. And finally, the NIMBYism. If you work in the field, I imagine that you heard that a lot. We talk about NIMBYism when, for example, neighbors do assume and believe that harm reduction services or services that cater to people who use drugs are needed, but they don't want it in their area, in their backyard, which makes it very difficult because if everyone has that posture, then they cannot exist anywhere. So that's on systemic barriers. And now I'm gonna move to the most positive part, which is what can we do? And I'm gonna only focus in the three types of services that we can integrate, where we can integrate harm reduction and homelessness, but there's homelessness services, but there's an array of creative ways of doing so. So I'm sure that drug consumption rooms have been a lot in the public discourse nowadays. I feel like so many people maybe already heard about drug consumption rooms, which are facilities where people who use drugs can use drugs more safely. And where people usually monitor drug use. So workers monitor drug use to help and support people in doing so. I brought two different types of drug consumption rooms. This one on the left is the drug consumption room I worked at in Amok in the Regenboog Group Amsterdam. And it's a drug consumption room that aims to promote, above all, relationships among people who use drugs, and that's why they use in circle tables. And then there's drug consumption rooms that that follow the model to the right. I also want to say that many drug consumption rooms are already integrated with known homelessness services like drop-ins. For example, the one at Amok is integrated with drop-ins. For me, what is interesting to also communicate to you is that drug consumption rooms are also a space where people can just be, like drop-ins are. If people are experiencing homelessness and then they are spending the whole day on the streets, it's really important that they can have a space where they can just take some rest from the hardships of the elements. And drug consumption rooms can be one such place because they cater to specifically to people who use drugs. What we know as well is that very often drug consumption rooms that are integrated like in drop-ins, from a study that we did 2 years ago, they cater to 100% people who are experiencing homelessness, whereas, for example, mobile drug consumption rooms cater to 10% of people who are experiencing homelessness, which means that other visitors are not experiencing homelessness. And that is interesting just to remind us that people can be using drugs and in need of using harm reduction services such as DCRs and not be experiencing homelessness. Of course, not always is possible to offer drug consumption rooms with shelters, which would be ideal. It's not always possible in the same building, especially. But that can be an example of a good cooperation. Is a drug consumption room collaborating with a shelter, a drug consumption room being placed in the same place or the same area as a night shelter, and making sure that people working in the night shelters or in the accommodations also follow a harm reduction approach when receiving people who use drugs in their facilities. I think it's really important. We saw how low it is, the access of people who use drugs to shelters according to our focal points. I think it's really important that we focus in the next years to increase the number of shelters, but especially 24-hour shelters where people can actually live, and that we promote the transition from shelters to housing. Now, speaking of housing, sorry, I forgot that I had this slide. So if you're interested in checking out the documentary about drug consumption rooms, please scan this QR code. I can also send links at the end, or I can send them to Sylvia and she can put it in the recording post. It's a very interesting documentary, just to let you know. So speaking about housing, if you're working in the homelessness field, I'm sure that you have heard about Housing First. Housing First is an excellent example of how harm reduction and homelessness services can intersect. Housing First is based on a harm reduction philosophy. And Housing First intends to ensure access to permanent long-term housing without the condition that people need to be abstinent from drugs or without almost any preconditions. It's needs-based and is person-centered. So that's really important for any person, but especially for people who use drugs. So that means that the care is always provided based on the needs and respecting the decision that people have towards their own lives. In these kind of services, usually social support workers accompany people that are in Housing First facilities, and they also take care of administrative formalities. Housing First is, in my opinion, a great example on how housing is harm reduction and is in itself care. Now, I also really like to talk about an example that we know from the Netherlands, that is Legel des Heels. That is a 24 sheltered housing where people who use drugs can live without also having to quit drugs. And in Dominus, people can use drugs in their own rooms. So that's a really interesting way of taking the barrier to care for people who use drugs, and a very interesting way of providing a safe space for people who use drugs, because a safe space can also be just being in a sheltered place using drugs. So the idea is that when people are on the streets, they have the constant instability, constantly looking for shelter, the insecurity of the streets, the lack of sleep, which in itself can lead to some downhill behavior. If you work in a shelter or a drop-in center, maybe you already felt that you see people coming in, and after 1 month, you see people completely different. They start to really go on a downhill of sadness, of care, self-care. So we can see the streets roughening up a person. And in Domus, they give an opportunity for people to escape that stress of street life. And that reduces many times drug use, it stabilizes drug use, it reduces criminal acts, and people become more committed, and there's more safety also on the streets, for example. So agreements are made about substance use in the facilities. And in the end, the results are very positive. And I want to say, I realize I didn't say along my presentation. When we say in harm reduction that abstinence is not our what we are looking for, that doesn't mean that when people want to access abstinence services, that we will not guide them towards them. We will, as long as it is their own choice and not a mandatory criteria for people to access services. Okay, reaching the very end, just want to leave with some practical tips on how to have a harm reduction informed practice. I know that very often when we talk about harm reduction, and things can be very abstract. And as I said before, I completely understand if people are afraid with dealing with certain situations. It's completely understandable. So I wanted to move from that and try to give some more tips. So just to start with the basic, harm reduction is a pragmatism approach, is a pragmatic approach. So an approach where we accept drug use is part of our world, and we focus on less, and we know that some drug use behaviors can be less problematic than others, and less functional or more than others. But we also assume that there's non-perfect health behaviors, and that we all do non-healthy behaviors. We can also discuss that in the Q&A part. So as such, we replace abstinence-oriented goals by goals that support the management of drug use, for example. So drug use that becomes more functional towards the needs of the person. Harm reduction is also humanistic, so we adopt a non-judgmental, non-stigmatizing, and non-coercive approach. That's maybe easier than to say, but that starts with not judging the fact that the person uses drugs and understanding that people use drugs for so many reasons, and not obliging people to be abstinent. We adopt a very low threshold approach. We want as little conditions as possible so that people can access services, because we know that many conditions can often be re-traumatizing and can result in a difficulty to develop trust. So maybe that means, for example, not asking for IDs for example, people who are migrants and are afraid of their situation, or any other person that does not want to connect their identity with drug use because they know that there's stigma. It can be bureaucracy, and it can mean what we already talked about before, abstinence. So we meet people where they are. That means that we accept the person as they are.
Sabes uma coisa? Ele trabalhou aqui durante anos.
Gonçalo,
Ele era
desculpa,
informático na
você
manutenção militar.
tem o microfone ligado.
Falei com ele hoje de manhã, mas encomendei-lhe um serviço.
Sorry, I spoke in Portuguese because I understood that this person was speaking in Portuguese and it was easier to pass the message. I'm Portuguese, I forgot to say that. So we promote safer use rather than no use at all, and we promote well-being. And we involve all these people because people know better about drug use and experiencing homelessness if they have experienced it than us. Now, as a person to do so, it's very important, as I said before, that you learn about drug use. As I said before, like drug use patterns can have different needs, and different drug uses of different drugs can have different needs, and it's important that we are aware of that if we work with people who use drugs. Even if we are not interested in drugs at all, I know some people are very interested, some people are not. It is our responsibility if we want to be inclusive. That we know that different vulnerabilities intersect, like homelessness and drug use vulnerabilities intersect to, for example, for double stigma, but also for conditions like communicable diseases being more easily to be spread, but also with gender, with migration, with incarceration. Know that what kind of stigmatization and barriers comes with those factors. For example, if I think about women, maybe we have to think about the possibility for harassment, which we know it's very common, and violence on the streets. So we need to consider that. For migrants, for example, we shall consider that there will be hostile regulations, that there will be language barriers, and therefore we have to consider that when hosting our services. It's really important that we focus in building a trust relationship that can do wonders. Without a trust relationship and without a relationship that doesn't, we cannot really work with the person. Of course, my background is psychology, so this is extra important for me. But from my experience working in the field, that's also what people are looking for, to see if they can trust you. So I think this goes without saying. To do so, you have to listen empathetically and create a safe space, not being judgmental, and as well as creating space for people to not trust us at the beginning. Maybe they will take some time to trust us. So another thing you can do as well is to encourage reflection on consumption, and that goes hand in hand with managing consumption. So in which ways can people use their drugs in ways that are more functional for them? And foster self-care and autonomy. Respect decisions and acknowledge that people who use drugs have skills, and not recognizing those skills is quite paternalistic, that we do not know better than people. So not taking unilateral decisions and respecting people's priorities. Being person-centered, that's what I said before about acknowledging that every person has different needs. Adopt, for example, a research-based approach. So recognizing the skills, capacities, and the person who uses drugs' strengths to guide them into more functional ways of living, if they want to. Provide information it can be about drug use, safer ways of using drugs, about the system, so many things. Not pressuring people to go in a way that we think is correct for them, or not pressuring them also when they have their own needs and they are taking more time to get there. And know your limitations. If you don't think you can deal with people who use drugs, then do or deal with certain conditions that come with it. Please just guide the person to someone else that can connect with the person better, or with another services that can connect with the person better. For policymakers, I just want to leave the message that it's really important to support implementation of harm reduction, or at least harm reduction services, or at least services that have a harm reduction philosophy. Ensure that services are low threshold. I'm not going to focus on that because we already talked a lot about it. Ensure housing over emergency and temporary accommodation for people who use drugs and are other marginalized groups. And also support the transition from shelters to permanent options. Make better use of EU funds for investments, which allow rehousing and improving access to housing. Enable state funding for people for harm reduction services, because the lack of funding, as we unfortunately might be seeing now, leads to a downhill of challenges, including public health risks. And allow flexible use of funds in a way that supports the establishment of cross-sector integrated service provision, that we know that one services cannot offer everything. Allow for the conditions for state funding to not be centered in detox treatments, and that detox treatment should be based on individual choice, emphasizing people who use drugs agency, and setting community integration as a long-term goal. This can be used as I said, conditions for state funding. Okay, this will be it for me talking. I know that was a lot. A few years back, we also focused on drug use and homelessness together with Fianza in another project that was called HR for Homelessness. The training resources are still online, and if you want to access them, you can scan this QR code, and we can also add them to the description of the recording. Thank you so much, and I hope I was able to keep your attention.
Thank you so much, Joanna. It was really, really interesting. And for sure, the homelessness sector, but also mainly the housing policies and access to housing needs to work more for people that are using drugs. Also, she gave a lot of resources. Also, Fianza just published yesterday a paper on the intersection between drug use and homelessness. We will drop it in the chat if you want to read it more calmly. So before jumping to the Q&A now, but please, if you already have questions that came out during the presentation, leave them in the chat. I just wanted to take a couple of minutes to update you on what's going on at the European level. Just a second. Okay. So maybe you already know, at the moment we are during the EU drug strategy 2021-2025, so it's finishing this year. And what does an EU drug strategy? This strategy from the European Union are framework for policies, but just remember that the responsibility for drug policy stays between the member states. So it's not that EU is going to change what's happening in your countries, but for sure it can frame it. The current strategy has three principal area on policies, which are reducing drug supplies, reducing drug demand, and addressing drug-related harms. As we can see, it stays mainly on the part of crime and not really on the part of harm, which is problematic because it's not considering people who are using drugs, it's not considering human rights, it's not considering vulnerabilities, and so on. This strategy, however, allows the cooperation within different agencies. For example, there's a strong cooperation with the European Union Drug Agency to inform better the policies, to do research, evidence-based work, also to monitor what's happening on the drug supplies and being able to send emergency information and alerts if the situation will change. But as I said, the competence stays within the member states. In the current strategy, we can see a little bit of homelessness, not much. Homelessness is included in these 3 actions from the action plan based on the strategy. So on one side, when it talks in Action 29 about the prevention and measures that need to work on prevention, it has a focus on people with multiple disadvantages, and it includes homelessness in one of those. In Action 32, it includes an attention on vulnerable, non-discriminatory, and gender-sensitive access to effective evidence-based when it comes to drug treatment, and I would say drug services in general. And in the end, in Action 44, when it talks mainly in access to health, but with a specific focus on transmissible infection disease. It's have a focus on people with multiple vulnerability, and when a focus comes to tuberculosis, they're talking about also people experiencing homelessness. However, you can see the strategy is coming to an end. The Commission and the European Drug Agency have done a report on an evaluation on what's was achieved during the strategy. You can find it in the link below if you want to read it. And it's clear that the strategy and the action plan have failed in the coverage of harm reduction across the EU. Overall, most of the member states are falling below the World Health Organization targets around harm reduction. Due to just 17 countries out of 27 are collecting the data about this, and just 5 of the member states are actually achieving the World Health Organization targets. Then we are failing in reducing the number of overdose deaths, are actually increasing. There are still a lot of inequalities in access and continue to care mainly for infectious diseases among mainly migrants. And as we can see, this strategy has just a few articles on homelessness and it's not reaching them. And unfortunately, I don't have better news for the future. As Joanna was saying, we are facing a big reduction in fundings for harm reduction services. And at the moment, the Commission is drafting the new strategy and the new action plan that will cover 2026 and 2030. And what we know so far is that the new strategy wants to keep a strong focus on crime and trafficking and controlling drugs, and even the small part that was included before on the harm and supports for people that are using drugs, it's falling even more out. So at the moment, there's an open public consultation that everybody can give their feedbacks on what they would like to see and what the new strategy should look like. You're also able to send documents, reports, resources, but it's ongoing just until this Friday. So if you want to give a feedback and try to bring the attention to the importance of harm reduction and human rights-based approach, please do it. We will drop the link of the public consultation in the chat so you can access it. But we also know that most of these strategies are going to be drafted by DG Home and not DG Sante, which for those of who are don't have much knowledge about the European Commission, it's basically, as I said, not including the health part in it. However, we still would like to see strengths in participation and more involvement of people that use drugs and people that are experiencing homelessness in the drafting or the strategy and the monitoring of it. We would like that homelessness has a bigger focus on it because we know how much, as Joanna said, and as our paper shows, how much people are experiencing homelessness are highly affected by harms related to drugs, way more than other people who use drugs. And we also know how much the rights and access to housing, it's a harm reduction strategy to reduce this harm. So we would like that to happen. We would like to that we can guarantee healthcare access, so we can reduce all these barriers that we are talked about it until now, and that we can combat the stigma. So just so you know what's going on at the European level. And to the questions. Also, if you would like to just raise your hand and ask directly the question, feel free to do it. So far, we have a question from Warsaw in Poland. So how applicable are harm reduction practices for supporting people using drugs to supporting people whose major only substance use is alcohol? Please share your experience.
Yes, so yes, there's definitely harm reduction strategies for people who use alcohol. Also knowing that for many people, stopping with the use of alcohol can mean that they have quite some problems physically. I find that a very interesting approach. In Amsterdam, for example, a few years back, there were inclusively drug consumption rooms just for people who use alcohol. So that's a way of using. There's also a set of best practices and recommendations that can be used for people who use alcohol. So maybe we can share that afterwards. And I don't know if I would like to invite anyone that has an experience and wants to share their experience with it, please do so, as well as with any other topic. But in short, yes, the answer is there are strategies, harm reduction strategies to address alcohol use.
Also, just to say, drug consumption rooms in some shelters also includes rooms to consume alcohol, which is also really useful. I see that there are some questions about the link for the documentary, etc. If you want the presentation that we presented here, if you want others access to supporting material, you can always email us at epoch.practice@fianza.org, so we can forward all this information to you, or you can contact directly Joanna. We also have a short experience from the Azores Islands. I don't know who, if you want to take the floor and share your experience, or you want me just to read what you wrote.
I just wanted to share that we have a shelter for people that use drugs, and they don't need to be abstinent to stay in the shelter. But the only downside that we see is the limited number of beds, because we can only have 30 people, and there's a lot more people sleeping in the streets. But so far it's working okay. And we started with housing first method to approach. And we have now 5 houses, and it's working very well. It's just to share our experience.
Great, thank you. And also for the ones that have shelters or other housing solution for people experiencing homelessness, and they cannot include a safe consumption room. There are so many things, as Jan already said, that can be done. Also, the correlation has work on, for example, how to make the bathroom of a shelter more safe for people who use drugs, and a lot of other small details that can be done when the policy framework of the country where you live or the building are not easy to have a different approach. Joanna, you wanted to say something else?
No, I was saying yes to what you said. That's also something that we worked before in correlation, is to move from this idea of only having drunk consumption rooms and more making spaces where people who already spaces where people already use more safe by, for example, what I said before with shelters, providing paraphernalia and providing boxes, for example, safe boxes for people to discard paraphernalia, checking if people are too long in these spaces, in the bathrooms, for example. Very often we know that people are using, and instead of always stopping them from doing so, maybe it's good to just assume that it's going to happen. And try to monitor to see if something happens. I also want to say that from my experience, because I think very often people are very scared of overdoses, and my experience in the drug consumption room was that when you do provide a safe space and knowledge and skills for people who use drugs more safely, overdoses are not that common. In my time there, I think I experienced one overdose. So I think that's also important to know, and I think that takes the fear. I also want to comment on the fact of the shelter in Azores is working well. I would like even to know if you would like to share which positive results you see. But I also I understand the struggle with not having enough beds. I feel like I heard this all over Europe, and that's also why I want to urge policymakers to make available funding for it.
And also we have a question regarding, as you mentioned, housing first and working with migrants. And they are asking if you could share more details about this experience and how did it work in practice.
I'm not sure if this is related to my own work experience, because I didn't work in the housing first, or but it doesn't matter. I can talk about both. So my experience with working with people that are migrants in Amsterdam is that their rights are very scarce. So I worked with European migrants, so at least European migrants already have the right to be in the city, so that's good. Because for many people that come from outside of Europe, we know that one of the main problems is that they cannot even be in the country. But the rights of European migrants stop there. So they do not have the right to any other types of social welfare that citizens have. And in Amsterdam, in the Netherlands, for example, to have access to that, you would have to be working for 5 years. So that was the main challenge. For us, honestly, working with European migrants, it often felt like there's no way out, and that the only way out was to suggest people to leave, which is something as a migrant I despise. I find it very difficult to do. But I do know, for example, in Lisbon, I've been to a housing first program there, and there was no difficulty in integrating people who are migrants in the facilities. They were just assuming that people need and therefore they needed to access it. And then they would have workers that would speak different languages, and that would accompany the case as they would with any other case. Does this respond, or please tell me if it doesn't.
I guess so. So I think we can close the webinar here as there are no more questions, but as we said, feel free to contact us and reach us. And as I said, our next webinar is going to be about our briefs on good practices on tackling homelessness, and we do have a few practices on harm reduction. So I'm going to share it. If you want to scan the QR code to register for the next webinar, and thank you so much to Joanna to be here with us and sharing her knowledge, and for everyone that participated. Have a nice rest of the day.
Thank you. May I ask you one question, please?
Yes,
you can.
sorry. I was muted.
I actually wanted to ask the question to the organizer. I know Correlation Network, you had a great conference in Warsaw last year. I still see that you are more knowledgeable in drug use, and it's a bit an issue for me because in Poland the major substance is alcohol, and that's the substance that our customers in Housing First programs use. Somehow the drug system is separated from the homelessness system in Poland, right? It's different, but that's interesting field for me to research more. But I have a question about the next webinar, because actually our program Ambivalence, which is based on Housing First values, is one of the good practices. We are very happy to be mentioned. And I wanted to ask for more like practical details. If you will let us know if we could present our practice on the webinar, or because there is as much as 10 of them or even 15.
Arno, would you like to jump in?
Thank you